Okay. Hello, everyone, and welcome to this session, Navigating the Health Insurance World. Our speakers are Andrew Toy, who is an board member of the Marfan Foundation, and CEO of Clover Health, which is a Medicare Advantage health insurance company. Kara Toy is Andrew's wife and is actually navigates the insurance system for him totally. And so she's here to share the personal side of this situation. I am Jan Lynch, a nurse and the director of the Help and Resource Center, and I'm happy to be with you. And now I welcome, let me just say one other thing. As you listen to the presentation and you have any questions for Andrew and Kara, please use the Q&A option at the bottom of your screen. The chat box is also available for connections and comments to one another. I hope you benefit from this presentation.
Okay. Hi, everyone, and thank you for joining us today. As Jan said, my name is Andrew Toy. I am the CEO of Clover Health, which is a Medicare Advantage company. And with me today is my wife, Kara, who actually is my personal care navigator when I navigate the healthcare system for my own conditions. And I'll talk more about that in a second. Let me just make sure that we can share. And we share here. Okay, so let's talk about the healthcare system. And just to be clear to everybody, today I'm talking about how we navigate insurance and the role of insurance in the US healthcare system. If you're joining from overseas, this will not be the same in your local country, but the US has a very specific system that hopefully this will be helpful to everybody as we take you through how your care is paid for and how to get your care paid for. So who am I? My name is Andrew Toy, like I said. I am the CEO of Clover Health, and we are actually a Medicare health insurance company. So I work on health insurance every day, specifically in the Medicare population. And that's something I'll talk more about in a moment, but I won't only be talking about Medicare. We'll be talking about all kinds of insurance. I actually have Loeys Dietz type 4, and I also have a fibrillin mutation. So I was for a long time in the Marfan category. So I think of myself as having Marfan and Loeys Dietz because I was in Marfan for a long time, and I now also have Loeys Dietz. So shout out to all the Marfs and to Loeys Dietz as well. My father unfortunately passed away from his aortic dissection. He had 2 dissections, and that's how I ended up getting diagnosed back in the late 90s. And so obviously have pathology in my particular family history and have been managed for a very long time. Kara, my wife, who's here. So 2 dimensions. On my professional side, I work on health insurance every day. And in my personal life, I have to navigate the health insurance system. And Kara pretty much does all of that for me, because even though I am the CEO of a health insurance company, it's still a lot for even someone like myself to navigate health insurance. So Kara handles prior auths, getting me my scans, making sure they're the right kind of scans, peer-to-peer reviews, making sure that we don't get the Loeys Dietz and the Marfan side confused. Lots of that stuff coming. So together, I'll be presenting, but Kara's here to help answer any of the questions that you might have as well. So our goals for today, and please do ask questions as you go throughout, and you can ask about your own situations, but we want to keep this at a high level. Throughout, I will use Marfan as generally a catch-all for connective tissue disorders. It's just quicker to say. But when I say Marfan, rarely will I mean specifically Marfan. I mean any kind of connective tissue disorder. But we'll use it as a shorthand. The first goal, helping you all understand how the US healthcare system works. It's very confusing. I know we are all generally more exposed to the healthcare system than most people, but it's still very confusing. And understanding how it ties together may be helpful in helping you navigate it. Second of all, critically, ensuring that you and your family, friends, or whoever has the condition in your circle can stay covered, meaning can still have access to health insurance and can therefore access care, right? Looking after a chronic condition, congenital condition like Marfan disease, it's very expensive. And so it's very unlikely that anyone's going to be cash paying for that. You will need some kind of health insurance to cover that. And there are multiple ways to get that health insurance. We will discuss that today. And then, of course, answer specific questions and scenarios that you might have. Everyone's situation is so individualized based upon where you live, what doctors you're seeing, what kind of insurance you have, your economic situation, like lots of different scenarios. Do not be confused or worried if what I cover in the general material is not exactly what you're thinking, because it's so individualized. Please do ask questions, and we'll have an email address to ask questions to later. Anything? All right. All right. So you don't need to memorize these, but common insurance terms that we will use in the beginning to make sure we're on the same page. Network. You might hear the term provider network. You might hear the term insurance network. These are the set of doctors you can see at a certain level of cost. Normally, you'll hear something like, is someone in network, right? And so if you say to yourself, can I go see X doctor? Don't think of it that way. Think about the fact that there are different tiers of network within any kind of insurance, and your obligation to pay is different depending on where the doctor you want to see sits in that network. The simplest version is in and out of network, but there's often tiered networks. There might be geographic networks, and we'll get into more details later, but just have that concept in your mind. Not all doctors are the same. There's a relationship between a doctor, the health system they work for, and the insurance. So a doctor might be in network with one insurer, let's say Aetna. They might be out of network with United. Even more confusingly, that same doctor might be in network with Aetna when they work at one hospital, but they might work at two hospitals. They might be in network when they work at the other hospital. It's very confusing, but just have that general concept in mind that it is confusing. Copay and co-insurance. These are the amounts you pay as the patient out of pocket. Out of pocket meaning from your funds, right? The insurance will pick up the other portion of it. Copay is normally referred to when it's a fixed dollar amount, $10, $50, $100, $1,000. Examples of copays. Co-insurance is a percentage. If that scan costs $1,000, you might have a 20% co-insurance. That means you will pay $200 and your insurance will pay the remaining $800 in that case. Generally, for expensive things, copays are going to be cheaper than co-insurance, therefore, for obvious reasons. But think about it that way. So one is the network, who you can go see and go and not see. But then there's different tiers, which is depending where they are, the doctor is in the network or the health system, your out-of-pocket obligation shifts. Maximum out-of-pocket. Not all insurance plans have a maximum out-of-pocket, unfortunately. But where you do have one, this is the most you will pay normally in a given year before your insurance pays everything. So that means you pay, and then at a certain amount, the insurance will shift and you will have no copay or co-insurance, and the insurance will pay everything beyond the point. So not all plans have that. A lot of Medicare plans do have that, but not all plans have that. But just in case you have one, that's an important concept. A covered service and prior authorization. These are somewhat related. A covered service is what the insurance is willing to pay for. Now, you might say, shouldn't they pay for everything? Well, no, there's different kinds of health, right? So one simple way to think about covered services is there are things that might be medically necessary, right? Because of either pain or because, or like life-saving procedures, medically necessary. Cosmetic procedures, as an opposite, are rarely covered by insurance, right? If you're doing something because it's aesthetic, as a cosmetic issue, the insurance may not cover that service. So that's an easy way to think of where covered services come in. Now, you might say to yourself, well, isn't like Marfan and Lois Dietz, aren't these kinds of things bad, certainly like really medically necessary? Well, yes, but this is important for you to think about your medical necessity around your aortic health or your vascular health may be very medically necessary, but you might have dermatological issues too that's related to connective tissue, right? Maybe those are not medically necessary in the eyes of your insurer. Maybe you have pain issues. They may or may not be medically necessary. Maybe you have orthopedic issues. Maybe your durable medical equipment may or may not be medically necessary. So think about that this is just all tiers, every single individual service on a condition by condition basis, the insurer is deciding whether they will cover. I will get to prior authorization in a moment, but for prior authorization, that is saying, even where it's covered, is it covered for you? Right? A very easy example of this is genetic testing. Insurers are not going to pay to genetically test every single person to see whether they have Marfan. They're just not going to pay for that. It's too expensive. So what they're going to want is evidence that you are at risk of having Marfan so that they will then cover the genetic test. And that's where something like prior authorization comes in. They're going to say, we might pay for this, but prove to us that you need it. And which might seem a little unfair because for most of us in this community, we know we need it, but don't think about it that way. Think about it as well, what if we didn't need it? What if we just maybe someone had Googled for Marfan and said, well, maybe I have Marfan. Let's do a genetic test. The insurer is not going to pay for that. If you say, my father, as in my case, dissected and died of aortic dissection at the age of 49, generally the insurer is going to pay for that genetic test at that point. More on prior authorization in a moment, but hopefully that sets your intuition as to how this stuff works. Anything, Gwen? Yeah. All right, let's keep going. So let's have this overall arc, the landscape of the US healthcare system. Providers, people who provide healthcare services. This is probably who you mainly are going to be interacting with, right? They're the doctors themselves, but there's also the nurses. There's the hospitals, the health, the pharmacies. Sorry.
PAs.
Oh yeah, the physician assistants, any kind of clinicians. You might be seeing a nurse practitioner. So MDs, DOs, NPs, PAs, RNs, MAs, like all of these folks, techs who run the radiology machine, anyone who's providing you with healthcare, looking after us, right? Those are generally thought as healthcare providers. They are providing healthcare. Payers, people who pay for healthcare, right? In the US, those are split. There's some places where those are blended, but let's just say that they're split for now. And they're saying, we're going to pay for that because you have insurance and you now need care from a provider. The provider is going to bill for that care that they render, and the payer is who is responsible for paying for that. As I said just now, they're not going to just pay for anything a provider does. There are gates for cost control purposes for the payer to say, am I going to pay for that? Or how much am I going to pay? Or how much am I, the payer, going to pay versus the patient? So that's where the payers sit in. And they are, in the US, distinctly split. More on that in a moment, but that's the second. Providers, payers, and the patients. That's hopefully fairly obvious. That's all of us, right? Or someone that you are looking after. They're the people seeking medical care. Patients seek medical care from a provider. When that patient has insurance, the provider bills the patient's insurance to get reimbursed and get paid for the service that they provided. When it's working well, that's the way it's meant to work. Probably already confusing, but that's the layout. Okay, this is a very high level view. Each of these sections merits like hours of discussion in and of themselves. But let me discuss the major ways you can get your care paid for. Let's start with the bottom right, actually, because if you ignore everything else, you can pay out of pocket. You can just go to a health system and say, I will pay. It's called cash pay normally, is what you say. Very rare, very, very rare. Because it's so expensive to get care here in the US that it's prohibitively expensive. But there are very specific places where you might want to cash pay. Mm-hmm. and we'll talk more about it in a moment. Like I have had quite good insurance, and Kara is excellent at navigating insurance. And there are still some places where it's smarter to actually do a small cash pay yourself in order to get a larger service than covered, right? An example I can give is genetic tests are often like a couple $100. Rather than fighting your insurer to justify the genetic test, it might be more efficient to cash pay and expeditious to cash pay for that genetic test, get your positive aortopathy gene confirmation, because once you have the genetic test results, you can use that as a justification to get further care that's very expensive. Hopefully that makes sense, right? Because the insurer will say, oh, you have Marfan, Lois-Dietz, you have the gene. Okay, that is now medical necessity to get an echo every year. Whereas if you're like, hey, maybe I need to get a genetic test, they're going to ask you things like, do you have an echo to prove that you need a genetic test, which seems circular, and that's, oh, it is circular, right? Or has anyone in your family died? Or you can't just go and, like show how bendy you are, and I'm quite bendy, and that's not enough. So cash pay does have a place. The other areas, commercial insurance. This is sometimes called employer insurance. This is the insurance most people have in the US. It's the insurance you get through your employer. It can be through a union, it can be through directly through an employer. There's various versions of this, but that's commercial insurance. Okay, so there your employer has a set of plans. You're picking from those every year. You get insurance. You still pay co-pays, co-insurance, all those things exist, but you're getting your insurance because you are working for a company. Then there's the ACA, the Affordable Care Act. Sometimes it's referred to as Obamacare. It's the same thing, right? Sorry?
Oh, I was saying the exchanges, yes.
Yes, it's also known as, these could something be called the exchanges, the individual exchanges. And here, these are relatively new. These are for people who don't want to or cannot get insurance through an employer, but will pay for or want to pay for insurance at a reasonable rate. It's actually quite expensive, but it's still reasonable compared to what it used to be themselves. And so you can go and buy your own insurance on these ACA exchanges. So that's another way you can get insurance. Commercial, you work for somebody. The ACA, you might be a contractor, an independent contractor. You might be not working. You can pay for care through the ACA. So those are the two options on the sort of like private side. Two government-run options, and these are often confused. They're two very different programs. Medicaid is for low-income people, and there is a income test. If you make over a certain amount or have a certain amount of assets, you do not qualify for Medicaid. You have to be below a certain amount. But then you can get health insurance coverage through your state, is the way to think about it. It's through the government, but it's through your state's government. Medicaid will vary significantly from state to state. Medicare, different to Medicaid, also the government, but it's the federal government for the whole country. And it is generally not tested on the basis of your income or your assets. It is for this, if you are 65 or older and have worked through your career, that's Medicare. That's what's most known for, seniors, older folks. But if you are disabled at any age and you are collecting disability on Social Security, and that's very complicated. I'm not going to go into disability a lot here, but lots to answer there. But if you are disabled from a Social Security perspective, generally you can get Medicare, even if you are not 65. And that is something that is not well known. And that is important for us and our community, because oftentimes people with connective tissue disorders may at some point in their lives qualify for disability and would therefore qualify for Medicare. Very important. And there's a couple other conditions as well. End-stage renal disease, which is basically you're on the dialysis or you need a kidney transplant, or if you have ALS, which is Lou Gehrig's disease. So those are the ways to get on Medicare. I am guessing for this population, for all of us, it's going to be if you're 65 or older, or if you are on disability, then you can go on Medicare. So those are the main ways. So I'm going to summarize it as it goes out over over here, actually, I'm going to go forward a couple. Let's just go to the sheet. Generally, I'm going to say that this is the order that I would recommend. It's not always the case, but if you want a very high level way of thinking about how to go over here, this is the sort of ordering of the logic tree in my mind. If you are if the person who is has connective tissue disorder is disabled or over 65, you want to go on Medicare, is what I would say. Not always, but like 80-20, you want to go on Medicare. And I would pick original Medicare with a Medicare supplement plan or a Medicare Advantage PPO. More on that in a second, but generally Medicare is the best for if you are disabled or over 65. Next, are you able to work and get insurance through your employer? If so, do it that way and pick the PPO. I'm going to come back to HMO and PPO in a second, but pick the PPO. Third of all, are you able to afford to pay a premium yourself because you have the money available? If so, buy insurance off the ACA exchanges, the Obamacare exchanges yourself, and try to find a PPO. Not all states will have a PPO on the individual exchanges, unfortunately. You might have to go with an HMO, but wherever you can, try and find a PPO. If you can't get a PPO, go with employer or ACA and pick the HMO. That's fine. But like, if you can get the PPO, do the PPO. And if none of those exist and you can't do any of those things, generally you probably, if you can't work and all those, you probably have low enough income that you can enroll on Medicaid, then go onto Medicaid, which is going to be a statewide HMO, right? But Medicaid is the option last. So first of all, disabled 65, Medicare. If you can work, employer, ACA, buy it that way. Through all those, try and get the PPO. And if not, go via Medicaid. So several times I've talked about HMO and PPO. Let's talk about that. Your care is highly related to your insurance network. We mentioned this earlier. Your insurance network are the doctors your insurance company prefers to work with. These are the doctors who they have the closest relationship with, where they understand how the billing works, all of those kinds of things. And there are two types. You probably heard the letters. You might not even know necessarily what they mean. HMOs tend to be lower out-of-pocket costs. So you're going to pay less out-of-pocket for premiums, co-pays, co-insurance. But they are going to limit you in terms of the doctors you can see. They're going to say, generally want to try have you see doctors within a certain network or even within a certain health system. Classic example of one of the most tight HMOs is Kaiser Permanente. Kaiser only offers an HMO. If you have insurance through Kaiser, you have to go to Kaiser. But they offer great care and services within the HMO. Maybe not for rare diseases, and we'll come back to that. But in general, it's a great service at a great price, but you have to go to Kaiser. If you ever have been told you need a referral for that, that means you're in an HMO. They also require to see a specialist, that your primary care physician refer you to that specialist. They require it, otherwise they won't pay for it. So if you've heard those words, you're probably in an HMO. If you've heard the words, oh, you know what, we can't provide that specialist care, but you know what, you can get a second opinion, you might be in an HMO, because what they're saying is we're not going to pay for that within the network, but you can go try and get a second opinion. And we had a question on that, which I'll cover in a second. That's probably all HMO dynamics.
Gap exceptions.
Gap exceptions? For which part of the
Just out of network.
Oh, what you mean for covering out of network stuff? Let's come back to that in a second. Yes, there are capabilities for you to go out of network with the HMO, but we'll come back to that when we talk about prior auth. So PPO lets you see a wider range of physicians, lets you go even out of network, but you will generally pay higher co-insurance and co-pays, which is why people don't pick PPOs. But it's much easier to go. Generally do not require a reference to see a specialist. You can just go see that specialist right away. You don't have to go through a PCP. You don't have to justify seeing that specialist, right? And generally has better coverage for interstate travel. So the thing about the HMO and the PPO is HMOs tend to be limited to the state you're buying the PPO in. And if you are on Medicaid, you are very restricted to the state that you are on Medicaid. That makes it harder for when you have a rare condition to go necessarily see doctors at our various centers of excellence. So if you want to go and see let's say Hopkins or Mayo, and you don't live in those particular states, you don't live in, say, Minnesota for Mayo, it may be very difficult if you are the HMO, because they will say, you should go and see our local cardiologist. If you're on a PPO, you can really see most of the time anyone, and as long as you're willing to pay that network higher out of pocket, that's a better option, I generally feel, for when you have a rare condition. So I almost always advise to go for the PPO because it gives you the most flexibility to see the doctor you need to see. If you want to just go see a new cardiologist, you can just go see a new cardiologist without having to go through your primary care physician to get a referral. And even then, they'll want you to see the cardiologist within the health system versus just being able to see the cardiologist you pick for yourself. So again, PPO is what we generally recommend over here. Okay. All right. So I showed this cheat sheet before. Now everyone understands why I recommend the PPO as an option. It gives you the most flexibility to be able to manage the care. And it's hard enough having a rare condition as it is without having insurance limit who you can see, for example. Let me give you another example of where PPO is helpful. Let's say you want to get a sleep apnea, like you're going to get a sleep study. Sleep apnea is correlated with connective tissue disorders, with Marfan, etc. Like I myself have done it. I have a CPAP machine, right? But you might have difficulty if you have an HMO justifying the sleep study if that HMO does not realize there is a correlation between connective tissue disorders and sleep apnea, right? And so whereas if you have a PPO, you still have to jump through some hoops. Don't get me wrong, it's not a magical thing, but at least you can go straight to the sleep clinic and then talk to them and navigate insurance. With an HMO, you might not even be able to go straight to the clinic. They will require you to go through your primary care physician to justify why you should even speak to the sleep clinic, right? So it's just one extra step you have to go through to try and get the care you need. Okay, so let's tie all this together a little bit. This is the arc, I feel, in terms of how you navigate the care journey. And we're going to touch on prior authorization, which I think many of you will have questions on or experienced at the end. Number one, you need to find a doctor. And a lot of people gloss over this, and it's a really bad step to gloss over. You need to find a doctor who you feel comfortable has enough experience with the connective tissue disorder to manage your care. Do not simply go to the doctor you've always gone to. Do not simply go to the first doctor who you've chatted with. Who is the most convenient doctor who's near you that you can reasonably go see that has experience with connective tissue disorders? The foundation has an ability to help you with this if you need to find a doctor or a clinic that specializes in connective tissue and Marfan. So you need to find the doctor you want to go see. You need to then get a diagnosis. I'm guessing if you're on this, at the symposium, you already have a diagnosis. So you've already navigated this phase. But many people are at this phase where they don't have their diagnosis yet. So you now need to get a diagnosis, and you need to get that care paid for to get the diagnosis. You could get a diagnosis through an echo, and that would show an enlarged aorta. It could be a genetic test. It could be a number of things. But as you're going through that, you will need that care to be paid for, and you will not be able to say, well, it's because I have Marfan, because technically you don't have Marfan until you have a Marfan diagnosis. That's a circular piece of logic, right? Because you might think you have it, but not in the eyes of the healthcare system. In the eyes of the healthcare system, until you have a diagnosis, you don't have that condition. So you need to navigate that care and make sure that you get your diagnosis. Next, once you have your diagnosis and we know what it is, you need a care plan, and your doctor will develop your care plan for you, right? That's probably a series of scans. Hopefully it's not surgery, but you might need to have your surgery at some point, and you're going to go through and make sure that that's documented, justified, and explained so you can get the care that you need. And hopefully that's just, annualized management of the conditions that you have that are in the syndrome. Throughout all of this, you will need to navigate prior authorization. So prior authorization simply is that step I mentioned earlier, where the insurer says, I might pay for that, but give me more details. Explain why you think you need this. And most of the time, those questions are directed at your doctor. Your doctor will be trying to navigate prior authorization for you.
You should assume that they're going to be asked.
Yes, you should just assume they're going to be asked, because our care is so expensive that, like, I've had scans like for like 10, 25 years. And just suddenly out of nowhere, they'll be like, hey, explain why you need this. I'm like, I've had it for so many years. And then Kara will just get on the phone for days to like explain it through. But the key thing here is just expect to be asked. It doesn't help to get annoyed or anything. It is annoying, don't get me wrong. But like, even I find it annoying. I work for an insurance company, but it's gonna happen. Just take a deep breath and prepare for it. The better prepared you are for it, the more realistic you are about it, the better the chance that you will get your care authorized. And you probably will be able to get it authorized as long as you're really asking for something reasonable. So why does it exist? You need to understand this, because this is so mystical, but if you understand why it exists, you will be able to navigate this better. And I just want to really emphasize this, and this can be confusing to patients. Doctors are experts at medicine. They are not experts at the healthcare system, right? They are not experts at billing. They are not experts at how to deal with health insurance companies. So they're becoming experts at that. That's not why they went to medical school, right? They went to medical school to look after patients. So your doctor may not you cannot simply rely on your doctor to navigate insurance for you. There's so many people, like Karen and I talk about this all the time, where patients go to doctors and like, hey, can you just do it for me? Because they see it as healthcare being connected. Do not rely upon that. You will not get the best outcomes if you rely on that. You should become an expert at navigating health insurance. I hate to say it, but that's why we're having this session today. That is critical that you think about it that way. If you have a doctor who knows how to do this, by the way, love it. Let them, that's wonderful to be able to do that, but don't expect it. Number one, insurance companies do not simply take the recommendations of your doctor. They just don't. Like, don't expect them to. They don't expect themselves to. There's nothing that makes them do it. There is no law that makes them do it. There's no law that says, well, a doctor recommends it, you should pay for it. That does not exist, right? And the reason for that is doctors do not all agree amongst themselves as to what the right care is. There is no one source of truth that can be relied on as to what the right care plan is. So because of that, insurance companies will treat every case as an individual, even the same patient over year, and ask the same questions over and over and over again. And what they'll basically ask is, why is this medically necessary in this particular case? They will not simply take the fact that your doctor ordered a test or ordered a procedure or ordered a drug as evidence. So they rely on what's called standards of care for these conditions. These could be academic papers. They could be sources like the foundation, which has a lot of documentation of these kinds of things. It could be expert opinions, like if you have Lois Dietz, like Dr. Hal Dietz is a expert opinion. Like if he recommends something, insurance companies will listen to him, right? His name is on the syndrome. They will listen to him, right? And they will push towards that. They might ask for what's called peer-to-peer, where they will actually have one of their doctors call your doctor, and they will have a medical discussion about why this is necessary.
You can ask for a peer-to-peer if they deny you. It's important that you can always ask for peer-to-peer.
That's a great point. If they deny you, you can ask for a peer-to-peer. Your right as a patient, and just don't be ashamed of doing this, is you can advocate and push for your care, and the insurance companies do have an obligation to make sure that they are following a process to get you the right care. So you ask for a peer-to-peer, they'll give you that peer-to-peer. Now, your doctor might not win that argument. There's a good chance they will, but they might not. But you will get the peer-to-peer where your doctor gets to talk to their doctor. So any deviation from these standards of care, or even if you're on the standards of care, they'll still ring you through all these things. But if you're off the standards of care, your insurance company will probably not pay. So what you're looking for is evidence that what you're asking for is normal for someone with our conditions. Does that make sense? Hopefully that connects to people. That's what you're looking for. So when recently, like the insurance company was like, why are you having 3 MRAs? I was having 3 done. It was just a few weeks ago. they were like, why not only 2? Kara went and found a paper that said all of these MRAs are recommended on an annualized basis. And they're like, oh, okay, that helps. Thank you. Don't assume they've read the paper. And that's really what the next point is. Most insurance company medical directors do not know how Marfan is managed. They might have heard about Marfan in medical school. They often have never even heard of Lois Dietz. They might have heard of VEDS, right? You cannot assume that insurance company medical directors know what these conditions are. They still have to do their jobs anyway. So our jobs will have to be to help navigate people through this with the papers, with the evidence, with all those things, so that you can get the care you need paid for. So if you're like, hey, look at this paper that it says this, your doctor might not be giving them that paper. They might just be saying, well, I think this is necessary. And then the insurance company says, well, I don't think it's necessary. Whereas if your doctor just says, well, here's a paper, like that shows that it's necessary, the insurance company will say, okay, got it. It's medically necessary, right? They are following a process, and they need to see the right sort of peer evidence and standards of care to authorize this. It can be one with a he said, she said, but it's difficult. And we're near the end here, and then we'll go to some questions. So what should we do? I think this is the last slide. Number 1, try to make sure you are under the care of an expert clinician. And when you are under the care of an expert clinician, they can help educate the insurer. So if you are going to one of our centers of excellence, those doctors are known for knowing what the standards of care are. They create the standards of care. They almost always win their peer-to-peers, or they win them on a very, very high case scenario, right? It's harder when you have a primary care doctor or just a regular cardiologist who's not an expert. They can still win, but it's the more esteemed your doctor is, the better. Number 2, make sure you have papers, standards of care prepared, so you know the evidence for what drives the care. Don't be like, well, my doctor said so. That is not something that insurance companies find compelling. Right? You need to find the academic work. You need to find the standards, ask the foundation, etc. And then be patient but determined. Generally, you can get it paid for. It might be frustrating, it might be annoying, it might take longer than you want, but you can get it paid for. You just need to keep at it, keep pushing, try different angles, and just not give up on it. Right? With the right arguments, insurers will generally agree to cover your care when it's medically necessary. Right? Especially with our conditions where it is medically necessary and it is life-saving or life-preserving care. And I mentioned the judicious use of cash pay as well. Don't be afraid where you can afford it, if you're lucky enough to be able to do that, to use cash pay on small items that help you get evidence you need to justify the bigger items. Genetic testing is the classic example. There are a few others like scans and blood draws and stuff that might be in the same category. Okay, so I'm happy to take some questions here. We had a few questions that were posted earlier as well. So Joe, do you have any questions to kick us off?
Here. Yes, sure. Thank you very much. That was a great overview of insurance and very reassuring to some patients who are going through really difficult issues with their insurance companies. One of the first questions is from actually Gretchen McCarrick, and I've recently heard about this as well. She's trying to, she recently is trying to argue for a patient's post-aortic surgery for cardiac rehab. Hold on. Is there any forward, and not realizing that this isn't on a list for automatic cardiac rehab coverage, is there any forward movement in this space or advocacy the Marfan Foundation could participate to get this coverage?
Yeah, so Kara can jump in here as well. So the way this works, and great question, Gretchen, is the insurer is going to have a list of, if you have X, approve, right? They don't have a list of, if they have Y, disapprove, just to be clear. It's if you have X, approve. The problem with having a rare condition is they're not necessarily disapproving. They just haven't thought about Marfan. I hate to say that. It just didn't occur to them to include Marfan a lot of times in places where it's justified. And I think in rehab, this would be one of the examples where I don't think anyone's going to disagree necessarily. It's just not going to be on the auto approval. So two waves of that. This is me as a board member saying this, I think we can do more as the foundation, and we're thinking about it, to educate the insurers to try and get our conditions on those lists. And we will work on that. Second of all, though, in the meantime, what we need to do is point towards, once again, the peer-to-peer and or the studies, having more of that information out there that we can just simply point to and say, look, this is recommended and in this particular case, indicated in this case. Insurers will listen to that. That is very credible to the insurer. And I don't know if we have one in this case, Gretchen, but if we have that, I would point to that, and we can start to build up that body of evidence, store it more centrally, and make it available to caregivers.
Right. That could be actually, I'm not sure if it is in the new AHA guidelines. I mean, that would be very, very helpful if that was in there.
If it's in those guidelines, that it will move into those auto-approved categories. There's no insurer is going to deny care that's in those guidelines.
Right. We have to take a look at that.
Yeah.
Okay.
Yeah, definitely.
The second question is, I am a housewife and have Marfan. Do I qualify to apply for disability in order to receive Medicare prior to age 65?
Yeah, so two different things there. Great, good question. Medicare is based upon, and your disability status is based upon your doctor being able to show that your condition prevents you from reasonably being able to work. It has nothing to do with your actual income. It's whether you can work or not, right? And so that's a whole different discussion, which I'll summarize very, very, very quickly. But there is a whole set of, you can talk to your doctor about that and say, do you think my condition and my symptoms qualify me for disability? And many doctors are able to have that conversation with you, even if they are not a Marfan specialist, right? Most of the things that prevent you from being able to work are not, like, they're caused by Marfan, but they're going to be things like chronic pain, which a lot of people have. So if in this situation you cannot work, not that you do not work, you cannot work, you can then go into disability and you can get Medicare. I'm overgeneralizing, but sort of.
It's best to talk with a disability lawyer in your state.
Yes, if you are on the question mark, then there are disability lawyers in the state. And there's a website called Atticus, ATTICUS, which is a company that helps people with this. You can look at that for disability.
Mhm.
A second question, because you said you're a housewife, I'm going to make sure I touch on Medicaid. Medicaid is based not on disability, but not based on your ability to work, but based on whether you work and your income. If you qualify for Medicaid, you could get insurance that particular way. But I just want to call out that Medicaid, I would consider to be the insurance of last resort. It is not the best form of insurance. If you can get Medicare, ACA, or commercial, that's the way to get your insurance.
Correct. And just to make a note, we do have a number of webinars on YouTube that talk about going through the disability process. One thing you should know that Marfan is not an automatic disability, as Andrew and Kara had said. So it's just not an automatic checkoff. And you have to really show that you are not functionally able anymore to work and carry on a job. Okay, thank you. Next question is, when speaking about being disabled, are you talking about those who are only drawing disability through Social Security, or can those that are on disability through their retirement system qualify for Medicare?
The answer is it depends on a case by case. The case that definitely qualifies you for Medicare is, and because you said retirement, it implies a little bit to me that you are actually over 65, which would also qualify you. But so this is a bit of an edge case, but it can occur. But the key thing here is the Medicare regulator, CMS, the Center for Medicare and Medicaid, which is part of the government, will rely on the Social Security Administration, right, to determine whether or not you qualify. So if the Social Security Administration believes you are disabled, and they need to sort of like flip that and turn that on for you, say yes, disabled, then the CMS will allow you to go onto Medicare. So the whole question mark would be, does the Social Security Administration consider you to be disabled? And that's what Joe's referring to here is you need to qualify. You need to qualify for.
Okay, thank you. So for a patient that has an ascending aortic aneurysm but tested negative for all known aortopathy genes, has many signs of connective tissue disorder from multiple body systems. Because the symptoms are similar to LDS, would other testing needed for other body systems be more likely to be covered if the notes say that she has an undiagnosed connective tissue disorder rather than LDS? Or does it really matter?
Very nuanced question there. But this is where my mind immediately goes to. If you, the first thing insurance, and I'm talking as an insurance company person, but like, so behind the scenes, insurance companies, the first thing they're going to think about this is this life-threatening, right? Because they really do not want to deny care that is life-threatening, because that's a really bad liability on their books, right? You've already had a dissection. I think that's what it said, right? If you've already had a dissection, I would not be, when you go through these prior auths, they might give you some trouble. They might be like, hey, justify it. And what you and your doctor will want to say is, you have already had a dissection. They are looking for the underlying cause. There is a risk that you will have another dissection if we do not find the underlying cause. That is why we are doing broader testing. Always connect it back to the thing that has got the most intense medical necessity. And the insurance company, when they think about it that way, is much more likely to authorize additional testing.
Okay, thank you. How do you find out how to talk to someone at the insurance company who can actually do something about an approval or who can provide the papers and such? How do you get past the gatekeepers at a huge company?
This is an excellent question, and there is no simple answer to this question. But what I will say is what you do is you want to connect it once again back to the key is even if you think you're being clear, it might not be clear to the person on the other side. If you say, but I have Marfan, I have Lois Dietz, that might not mean anything to them. If you say, I am at risk of an aortic dissection, or your doctor says those things, those will generally go higher in the queue and be more prioritized. So try not to be nuanced is what I would say in the words you're using. And when those words are entered into the case system within the insurer, they will automatically generally bubble those up higher because you are at higher risk. Hopefully that makes sense. Like, I obviously don't mislead anybody, but in our community, we are at higher risk, and the risk is of something quite devastating. So that needs to just be made very clear that is what is being managed. If what we're managing is, once again, we always use, I will use dermatology again. Like, we have stretchy skin and we have certain conditions. If you're managing a dermatological condition, there's not much you can do to get a lot of attention. It's just going to be a lower case issue. If what you're doing is managing your aortic health, your vascular health, and around the core sort of like healthcare issues of the conditions, just make sure those are constantly being
You can
emphasized.
always also ask for prior auth documents. So they have forms and things like that. You can always try to submit more things to get more eyes. So you can always ask for the prior auth documents. And they may mail them to you, they may fax them to you, they may email them to you, they may be online, and you can actually preempt sometimes, or you can go straight to ask for a peer-to-peer and just be, as we say, determined. Just keep saying, because they might not know what that means, and then you may get escalation there. If you say, just send me the prior auth documents, I will have my doctor fill them out, or I will help them fill it out, or I want a peer-to-peer. My doctor wants to have a peer-to-peer. And if the customer service rep doesn't understand what that means, at least you have escalation there, because they have to go find out what that means and send you the information.
Yeah, I think that's a great point. Like, don't be shy about just making sure that that these things are being said. Like, when I look at my own prior auth forms, I think the one we saw recently, I think it said Lois Dietz diagnosis, something. But if you're not getting results of that, try and get, like, I would add to that, father deceased from aortic dissection. I mean, it sounds like a little grim to do that, but that would cause them to be like, oh, we need to look at that one closer. Like that's the mindset you have to have, is what will draw eyes towards your particular case. And then their escalation system will generally pull it forward, because that's what they're doing to manage the risk.
Okay, thank you. So this person has a PPO through their work. However, they max out of the pocket pay and it hurts them financially every year. Do you have any tips?
So you have I think you're saying you have the PPO, but you hit your maximum out of pocket, which means your out of pocket spend is very high every year. So a couple of different things. So yes, healthcare is just very expensive in the US. So unfortunately, that's part of it. A couple of different scenarios, and this is a very nuanced topic. Remember, once you hit your maximum out of pocket, further care is 100% covered by your insurance. So if you can pull in more care into that year, that will all be paid for, if that makes sense, by the insurance company. So if you're going to do something in January and it can be done in December, do it in the December of the year you hit your MOOP, your maximum out of pocket. And that's very different from doing it in January, because your maximum out of pocket will reset when you hit the new calendar year. So not everything can be done that way. I get it. Like your scans, you can't necessarily all bundle together. But if you can do that, don't just let the care fall where they may. Look at your care and see what you can do, because while it's unfortunate that you're hitting your maximum out of pocket, that's a lot of money. Once you do, that it has a word maximum for a reason, you should be able to get additional care 100% covered by the insurance company. So that's one way I would think about it. Second of all, look at your sites of service and look at your co-insurance. Like it could be the case that even with a PPO, it's still cheaper to go in network. And if you're going out of network for any of your care, you might have something like a 25% co-insurance versus a $200 co-pay, right? A great example of this is radiology, where this very often happens. A 25% co-insurance means you are paying 25% of the total cost of that service. $200 copay means you are paying $200, right? It's vastly different when that particular scan might cost like literally $10,000 might be what is being billed. So look at your in and out of network and look at where you're going for your care and see whether or not there might be optimizations around that, is the second idea that I can have. Anything.
We always bundle scans.
Yeah. Like bundling the scans for our population is gonna be really expensive. The last thing I generally say, it's less so the case for our community, but like scans for the community is generally what I would say is for us. But drugs, right? Like drugs often have co-insurance as well. It might not just be copay. And if you are on expensive drugs, you can sometimes ask for generics if they are available for that particular drug. It tends to be less with our community, but that might be the case in your. Just know where your money's going.
Okay, thank you. So Blue Cross Blue Shield has a formula they follow to decrease the number of PT sessions allowed. PT has requested peer-to-peer, but they claim that the decrease is not a denial. By the last quarter of the year, PT has to request visits every 2 weeks. My son has to go 2 times a week. Is there any way to get around this?
I don't think I can do this question justice in like the amount of time we have here. So maybe you can send a follow-on to the email to the foundation, and I'm happy to look at it from there. My initial view would be pressure testing there. Limiting it is not a denial. I absolutely know what the argument they're trying to make is, but I don't think it's acceptable in this case, because PT is a very unusual one, but I think that what my initial instinct is, your son probably has an increased medical necessity for PT. Yeah, exactly. And it might be the PT who's doing the peer-to-peer. And what you want is to have your cardiologist do the peer-to-peer and say this is medically necessary. So that's the first instinct is whenever someone has a PT issue, again, one of these health insurance hacks, health insurance believes nothing a PT says. PTs, chiropractors, like don't even try to get them to do peer-to-peers. The health insurance company is just going to ignore anything they say. You want your actual doctor or for us cardiologists to be the one ordering these things. And I don't know if you've already done that, but that's where my first instinct goes.
Okay, great. Thank you. How can one get medical insurance to cover braces and or jaw surgery for Marfan? I can't find much in the medical journals to back this up. No standards yet either from what I can tell. Insurance keeps telling us they only cover braces for congenital dental/oral defects, but they don't consider Marfan in this category. But we know that a high arch palate is part of the diagnostic criteria for Marfan, and it does crowd teeth. Do you have any kind of advice for this?
Yes, I have less experience with dental insurance. I'm going to put out there. So orthodontics and stuff like that. Once again, I do agree that the literature is going to be more challenging here. My first instinct is similar answer to both before. Is it your dentist or orthodontist doing the pre-auth? Or is it your person who has expertise? Remember what I said when like they believe expert opinions? So what I would generally do, and I like to use Hal as an example here because Hal Dietz is going to be listened to when you have Lloyd's Dietz. Like if your cardiologist is Hal Dietz and he calls and he says, I really think this is medically necessary, they will take it a lot more seriously than if a dentist calls. I'm just simply saying what like the order. They will listen to the dentist or the orthodontist. That they're not the same as the chiropractic PT, but you want more specialization because you want to almost think about it as they want to be like, oh wow, an expert's calling me. I better listen to what they're saying. They do react to that versus just some person's calling for a service.
Okay, great. Thank you. So this question says, I am on a Medicare Advantage plan and will be needing surgery to fix my aortic aneurysm. I reside in a smaller area where I am limited with surgeons. My surgeon wants to do the procedure, but is not versed in connective tissue disorders. How do I get this covered in another area, possibly out of state?
Okay, so most Medicare Advantage plans are HMOs. So I'm going to assume that you're in an HMO. If you're in a PPO, you should be able to just be able to go over there and have that and just have that be done because it's part of the PPO. So my number one thing to say to you is switch to the Medicare Advantage PPO. I don't know how critical this is. And how soon you need to have your surgery, whether it's a little bit prophylactic and early or it's emergency. Hopefully it's a little bit early, and if it's early enough, you will be able to switch during open enrollment this September. Option number 2, try and call CMS and say you need a special enrollment period called an SEP right now because you have a condition that requires you to go out of state and you need to change to a PPO. If you call the government, then you call CMS as a helpline, the Medicare helpline, they may give you an SEP and you can change to a PPO right now and go out of state and travel there. Last option, you can call your HMO health insurer and basically do an out of area justification, which is to say there is not enough expertise in my area to do this surgery. I need to go to somewhere with a higher level of expertise.
So I come out alive.
And so I come basically, it goes well, is what I would say. You have a very good argument for that, and that would be the option I say. But I'm assuming you're an HMO, and in general, as per my other points, you want to be on the PPO for exactly this reason. But if you are on an HMO right now, try doing what Karen and I just said to an out-of-area authorization. And HMOs for this kind of surgery should be very open to doing that.
Okay. One question here is, are you using Medicare interchangeably with SSI? Or are they different? Please explain that.
Yeah, so I am not using Medicare interchangeably with SSI. Like SSI is a form within Social Security to actually do payments, basically. And so just think about it this way. Medicare is basically simply a form of health insurance. You can be qualified for Medicare for many different reasons. And again, we don't have enough time to go through all the ways you can get into disability, but disability is one of those, and disability is managed by the Social Security Administration, right? And so that's why we keep moving back and forth between those various terms. But what I do say is this: if you are on disability, you may, not always, but you may, if you are receiving disability payments, you may qualify for Medicare. If you qualify for Medicare, Medicare is one of the best forms of health insurance for our rare connective tissue disorders, because Medicare lets you go see any doctor in the entire country, right? And again, there's lots of ifs and mays in there, but if navigated correctly, you can do that. So I'm not using that there. I'm staying away from how you qualify for disability right now, but I think, the foundation will continue to do more content around that.
Okay, thanks. So this is one of the last questions. One of my biggest problems has arisen thanks to pharmacy benefit managers and the difficulty that they have caused with respect to their medications that they need to take and their cost. Are there any suggestions on how to handle this?
Yes, though I think I need more details. So I encourage you to send an email with more details. You should not be directly engaging with your PBM unless it's for prior authorization, which is handled by the PBM. So I'm just going to assume that's the question you're asking here, is that you are getting denied by like Caremark or something like that because they're saying for medical necessity. It is incredibly nuanced as it goes here, but think of it the same way as we discussed for prior auth in general. It just happens to be a PBM instead of a health insurance company managing your authorization. You want the most expert doctor calling to justify it, and you want to tie it to why this is absolutely medically necessary in your particular case. I don't have enough detail to go into it. If you want to let us know like the drug and the condition when you share your thoughts, we can give more details. But the PBM, all the PBM is a different company that the health insurance has hired to do prior authorization on their behalf, basically, but for drugs. The insurance company does it for procedures and office visits. The PBM does it for drugs. Conceptually, it's exactly the same thing.
All right. Well, thank you so much. This is really, really informative. We got a lot of information from this. Again, as Andrew has said, if you have additional questions, you can go to our website at marfan.org/ask, and we will try to answer your questions. But thank you again very much. I hope the session was helpful to everybody. I hope everybody has a very good afternoon. Take care.
Thank you, everyone.